Welcome to the Deep Dive, your shortcut to getting truly well-informed.
Great to be here.
Today we're embarking on, a really deep dive into a fundamental skill in understanding the human body, really a cornerstone of cardiac assessment.
That's right.
We received a stack of material, quite a bit actually, but one source really stood out, demanded our full attention. A deep exploration of heart murmurs, specifically chapter 42.
Yeah, it's quite a chapter, really comprehensive. It doesn't just skim the surface. It provides, almost a masterclass, guiding you step by step on how to really listen and interpret those sounds the heart makes, the subtle ones and the not so subtle ones.
Absolutely. Think of this deep dive as sort of joining the experts right at the bedside, learning how they translate what they hear with their stethoscope into a precise understanding of what's actually happening inside the heart.
Mm-hmm.
Our mission today is to peel back every layer of Chapter 42, explore each concept, every single detail, so you can truly master this information, just like the elite professionals in the field.
And we did get another related piece about edema, which certainly fits into the bigger picture of assessing a patient, especially someone with potential heart issues, swelling.
Right.
But for this deep dive, the real focus, the detailed roadmap, it's all within Chapter 42's approach to heart murmurs.
Exactly. Edema is important context, a potential sign of what severe heart problems can lead to down the line, but understanding the sound of those problems, that's our focus today. We're going deep on the murmurs themselves.
Makes sense.
So ready to unpack this. It's fascinating stuff.
Let's do it.
Okay, so where do we even begin with heart murmurs? The source starts with what sounds like a simple definition. They are audible vibrations.
That's the starting point, yeah. Deceptively simple. But those vibrations, they aren't just random noise. They are the sound of turbulent blood flow.
Turbulent flow.
Right. Normally, blood moves through the heart and vessels pretty smoothly, laminar flow. When that smooth flow gets disrupted, it becomes chaotic, turbulent, and that turbulence creates vibrations we can actually hear with a stethoscope.
Okay, so turbulence is the key. And the source lays out the specific scenarios that cause this turbulence. What are they?
Well, the first is when blood accelerates through normal or sometimes abnormal openings, or orifices, as the source calls them.
Mm-hmm.
Imagine, like, putting your thumb partly over a garden hose. The water speeds up, right? And it gets turbulent as it's forced through that narrower opening. Same idea with blood flow.
Okay, so speed through an opening causes turbulence. Makes sense. What else?
Then there's flow through a narrowed or irregular opening into a dilated vessel or chamber. So the turbulence starts at the tight spot, the constriction, but it can be amplified or changes character as it hits that wider space downstream.
Got it. So turbulence hitting a bigger, maybe less organized space?
Precisely. Then there's backward flow, which we call regurgitation, through a valve that isn't closing properly.
Leaky valve.
Exactly. Valves are meant to be one-way streets. If a valve is incompetent, doesn't seal tight, blood leaks back, crashing against the normal forward flow, that definitely causes significant turbulence.
Yeah, you can imagine that. Backflow causing chaos.
And finally, the source mentions flow through abnormal connections. Things like a hole between the ventricles, it's a ventricular septal defect or VSD, or a vessel connecting the aorta and pulmonary artery that should have closed after birth, a patent ductus arteriosus or PDA.
Right.
Blood flowing through these sort of unintended pathways creates turbulence because of the pressure differences between the areas and just the abnormal route it's taking.
Okay, so that covers the what audible vibrations and the why turbulent flow from these specific situations. But the source is really emphatic that before you even describe what a murmur sounds like, the absolute first step is accurate timing within the cardiac cycle.
This is non-negotiable, absolutely critical.
Mm-hmm.
You must know if that sound is happening during systole, when the heart is contracting and pumping blood out, or during diastole when it's relaxing and filling back up with blood.
And that means understanding systole and diastole relative to the heart sounds. S1 is the first sound, the lub, that's the closing of the mitral and tricuspid valves. S2 is the second sound, the dub, the closing of the aortic A2 and pulmonic P2 valves.
Correct.
Systole is the time between S1 and S2. Diastole is the time between S2 and the next S1.
Precisely. And based on this, the source defines the three main timing categories for murmurs: systolic, diastolic, and continuous.
Okay. Systolic murmurs happening during contraction. The source says they begin with or after S1 and they end at or before the relevant S2 component, either A2 or P2.
That's right. Then you have diastolic murmurs, which are in the filling phase. They begin with or after the associated S2 component and end at or before the subsequent S1.
And continuous murmurs.
Yeah.
They span both.
Yeah, exactly. They start in early systole, continue right through S2, and go into all, or at least part of diastole. This immediately tells you there's a pressure difference causing flow pretty much throughout the entire cardiac cycle.
Timing is clearly fundamental, but what if the heart rate is really fast, like an tachyarrhythmia? Can make distinguishing S1 and S2 tough. The source offers a classic bedside trick.
Ah, yes, the carotid palpation. You simultaneously feel the carotid pulse in the neck while listening. The carotid upstroke, the pulse you feel, happens very shortly after S1.
Okay.
So it serves as a reliable anchor. Feel the pulse, that's basically S1, and then time everything else relative to that beat. Really helpful when things are fast.
That's a great practical tip right from the source. Okay, so timing is step 1. Step 2 is characterizing the murmur itself. The source outlines several crucial attributes. Mastering these details is, well, what separates the novice from the expert, right?
Absolutely. The sound isn't just, there. It has specific qualities you need to describe. First up is duration.
Which, according to the source, depends on the length of time over which a pressure difference exists across the structures involved.
That's the key physiological insight. The murmur lasts for as long as that pressure difference driving the turbulent flow persists within that phase of the cardiac cycle systole or diastole.
Makes sense.
And this pressure dynamic, along with the sort of geometry and compliance, the stiffness or stretchiness of the chambers or vessels, influences the flow velocity and the turbulence, which in turn dictates all the other characteristics of the murmur, its pitch, its shape, its loudness.
So duration is a direct window into how long that abnormal pressure gradient is present and significant. Okay, next attribute. Character and frequency, basically, the pitch.
Right. High-frequency murmurs are often described as blowing. The classic example given is the murmur of chronic aortic regurgitation, or AR. Low-frequency murmurs are typically described as rumbling, like the murmur of mitral stenosis, MS.
And this is why you use different parts of the stethoscope.
Exactly. You use the diaphragm for high-pitched sounds like AR, and the bell for low-pitched sounds like MS. The bell filters out higher frequencies, making that low rumble much easier to appreciate.
Practical application right there. The source also mentions something called the Gallivardin effect. What's that about?
Ah, yeah, Gallivardin. It's a fascinating potential pitfall. A coarse systolic murmur, like the one from aortic stenosis, AS, which is usually loudest up at the base of the heart near the aorta. It can transmit down to the apex, the bottom tip of the heart. But when you hear it at the apex, it can sound much higher pitched, almost musical or acoustically pure.
Oh, interesting.
Yeah, so it can sometimes be mistaken for mitral regurgitation, MR, which is typically heard at the apex, if you aren't aware of this phenomenon. And don't listen carefully in other locations, too.
So location matters because sound travels, and its character can actually change as it travels.
Wow.
The source also notes some unusual qualities, like a honking sound, sometimes heard with MR due to mitral valve prolapse, MVP.
Some murmurs have these very distinctive descriptions that really stand out. Honking, musical, things like that.
Okay. Beyond pitch, there's configuration, or the shape of the murmur over time. The source describes crescendo, decrescendo, crescendo, decrescendo, or plateau shapes. These aren't just abstract shapes on a diagram, are they? They reflect the changing pressure gradient.
Precisely. A decrescendo shape means the murmur starts loud and then fades away. This reflects a pressure gradient that's highest at the beginning of that phase and then progressively declines.
Like with aortic regurgitation.
Chronic AR and diastole is a perfect example, yes. The pressure difference between the aorta and the filling left ventricle starts high right after the aortic valve closes, but it falls as the LV fills up and the aortic pressure drops a bit through diastole. So loud then softer. Decrescendo.
Okay. And crescendo, decrescendo, building up and then fading away, like a diamond shape.
That's typical of ejection murmurs, like aortic stenosis, AS. During systole, the left ventricle is ejecting blood through that narrowed aortic valve. The pressure difference between the LV and the aorta builds up as flow accelerates. It peaks somewhere in mid-systole, and then it falls as ejection slows down towards the end of systole.
Right.
This creates that characteristic diamond shape, building and then receding. You can see this conceptually in figure 42:1 in the source material.
And plateau, a flat shape.
That indicates a large, relatively constant pressure difference throughout that phase of the cycle. Chronic MR during systole is a classic example here.
Why plateau in chronic MR?
because the pressure in the left ventricle stays high throughout systole, and the pressure in the left atrium, which is usually enlarged to become more compliant, stretchier in chronic MR, remains relatively low.
Yeah.
This maintains a significant pressure gradient, driving that regurgitant flow back into the LA all the way through systole. So the murmur intensity stays fairly constant, a plateau shape. Again, figure 42.1 is really helpful for visualizing these different shapes.
Okay, so the shapes are directly tied to those pressure dynamics over time. Very cool. Next up, intensity. How loud is it? The source uses the standard 1 to 6 grading scale. This seems clinically very important.
It absolutely is. Grade 1 is the softest, often really difficult to hear. You might need a quiet room and focused listening. Grade 2 is easily audible once you tune in, but it's not loud. Grade 3 is loud, but, and this is key, you don't feel a vibration on the chest wall.
Okay, no vibration or thrill for grade 3. So when does the thrill come in?
Grade 4. This is the threshold where a palpable thrill usually appears. A grade 4 murmur is very loud, and it's accompanied by that thrill, that buzzing or vibrating sensation you can actually feel with your hand over the area where the murmur is loudest.
Got it. Thrill starts at grade 4.
Thrills generally mean a very loud murmur and significant turbulence, yes. Grade 5 is even louder, loud enough to be heard with just the edge of the stethoscope touching the chest. And grade 6, the loudest possible, is audible, even with the stethoscope held slightly off the chest wall.
Off the chest. Wow, that's loud. The source points out a really critical clinical takeaway regarding intensity. Grade 3 or greater usually indicates important structural heart disease and high blood flow velocity.
That's a key point to remember. While a soft murmur doesn't automatically mean it's benign, a loud one, especially grade 3 or louder, is much more likely to represent a significant structural problem.
And velocity is key.
High velocity is key. The source gives the great example of small, restrictive VSDs. These are small holes, but the pressure difference between the LV and RV during systole is huge.
Right.
This drives blood across that small hole at very high velocity, creating intense turbulence and often very loud, grade 4 or even higher murmurs. Conversely, think about a large atrial septal defect, an ASD. You might have high volume of flow, but the pressure difference is low, so the velocity is low, and the murmur is usually soft or even absent.
So it's really the velocity driven by the pressure gradient, not just the volume of flow, that creates the intensity. That's crucial. The source also notes factors that can decrease murmur intensity, potentially making a severe problem sound less alarming than it is.
Yes, this is vital context. Things that increase the distance between the heart and your stethoscope can muffle the sound, like obesity, severe obstructive lung disease, or a large pericardial effusion, fluid around the heart.
Okay, physical barriers.
Right. Also, reduced cardiac output, like in severe heart failure, can make a murmur softer simply because there's less blood flowing overall to create turbulence, even if the underlying valve problem is severe. And of course, a naturally low pressure gradient driving the flow will inherently result in a softer murmur.
So the take-home is, never judge severity solely by loudness. Always consider the clinical context.
Precisely. You have to put it all together.
Okay. The final attribute is location and radiation. Where is the murmur loudest, and where does the sound travel or radiate to?
This is another crucial clue about the murmur's origin. Figure 42:2 in the source is invaluable here. It shows the typical spots on the chest where different murmurs are best heard and their common radiation patterns.
So listening beyond just the loudest spot is important.
Absolutely. Seeing where that sound travels gives you critical directional information about the turbulent jet of blood. For example, an aortic stenosis murmur radiating to the carotids is classic. Mitral regurgitation often radiates towards the axilla, the armpit.
The source also reminds us to pay attention to other things we might hear associated sounds like systolic clicks or diastolic snaps and any abnormalities of the normal heart sounds, S1 and S2.
Yes, definitely. These adventitious sounds and changes to S1 and S2 often accompany specific valve or structural problems and help you further refine your diagnosis. An opening snap with a diastolic rumble points strongly to mitral stenosis, for instance.
And importantly, the source mentions that changes during respiration and with simple bedside maneuvers are also critical clues. We'll get into those more later under dynamic auscultation.
Yes, these maneuvers actively change the heart's hemodynamics. The blood flow dynamics and how the heart responds can really help unmask or confirm the diagnosis. Table 4201 in the source is presented as a conceptual guide, showing how you combine all these features, the timing, location, character, radiation, associated findings, and the response to maneuvers to narrow down the list of possible causes. your differential diagnosis.
It really is like putting puzzle pieces together. Okay, that gives us the framework for listening to any murmur. Now, let's dive deep into the specifics outlined in the source, starting with systolic heart murmurs, those happening during ventricular contractions.
Sounds good. We'll begin with early systolic murmurs. As the name suggests, these start right with S1 and typically end well before S2, and their duration can vary a bit.
The source focuses on a few key causes here. The first one sounds pretty serious. Acute severe mitral regurgitation, or
Yes. This is often a critical, sometimes emergent diagnosis. The murmur here is described as quite distinct. It's early systolic and decrescendo. It starts louder and fades. This is different from the holosystolic, plateau-shaped murmur of chronic MR we'll discuss later.
Okay, early and decrescendo. Why that pattern in the acute setting?
It's all about the left atrium. In acute MR, there's a sudden, large volume of blood being forced backward into a left atrium that hasn't had time to stretch out or become compliant.
It's unprepared.
Exactly. So as the left ventricle contracts, it pushes this large volume of blood back into this unprepared LA, causing the left atrial pressure to shoot up very rapidly. This quickly reduces the pressure difference, the gradient, between the LV and the LA during systole. So the flow and the turbulence peak early and then rapidly decline. That creates the decrescendo shape and limits the murmur's duration mostly to early systole.
So the LA pressure essentially pushes back quickly, cutting off the regurgitation early. Where is this murmur typically heard best?
Usually best heard at or just medial to the apical impulse, the point where you feel the heartbeat strongest.
The source highlights some crucial clinical settings where this acute, severe MR occurs. One major one is papillary muscle rupture, complicating an acute myocardial infarction, an MI or heart attack.
Yes, this is a truly devastating complication. It typically happens maybe 2 to 7 days after the MI, and it's often associated with sudden, dramatic clinical deterioration, worsening chest pain, sudden drop in blood pressure, hypotension, severe shortness of breath from fluid in the lungs, pulmonary edema.
Sounds dire.
It is. And here's a really key point from the source, a potential trap. The murmur, that early decrescendo murmur, may actually be absent in up to 50% of these cases.
50%? Wow.
Yeah, or it might be very soft, especially if the patient is in shock or has very low blood pressure.
Right.
So clinical suspicion has to be incredibly high, even if you don't hear a classic loud murmur in a post-MI patient who suddenly crashes.
That is a critical takeaway. Don't rule out papillary muscle rupture just because you don't hear a loud murmur. The source mentions one papillary muscle is more vulnerable.
Yes, the posteromedial papillary muscle. It's involved something like 6 to 10 times more often than the anterolateral one. The main reason is its blood supply. It usually relies on a single coronary artery branch, making it much more susceptible to ischemia and rupture if that artery gets blocked.
Okay. The source also contrasts this acute MR from papillary muscle rupture with another post-MI mechanical complication, VSD rupture, a hole tearing open in the septum between the ventricles.
Right. Both can cause a new murmur and sudden hemodynamic collapse after an MI. But there are usually key differences in the sound. A VSD rupture almost always has a palpable systolic thrill, that vibration, and the murmur is typically holosystolic, lasting throughout systole.
Whereas the acute MR?
The acute MR murmur, if you hear it, is early systolic decrescendo, and a thrill is much less likely. So the timing and the presence of a thrill are important distinguishing features.
So any new murmur or unexplained instability after an MI is a red flag, a medical emergency requiring rapid assessment. The source says transthoracic echocardiogram, TTE, is required.
Absolutely essential.
Yeah.
TTE gives you immediate information. It shows the mechanism, the valve leaking or a hole in the septum, and assesses the severity. It's crucial for guiding immediate management, which often involves urgent surgery.
And a right-sided heart catheterization can also help distinguish if needed.
It can, yes. By looking at oxygen saturation levels in the different heart chambers, you'd see an oxygen step up in the right ventricle with a VSD, and by analyzing pressure waveforms, particularly the pulmonary artery wedge pressure waveform, where a tall wave is characteristic of severe MR, reflecting that large regurgitant surge filling the left atrium during ventricular systole. Prompt referral for surgical repair is usually the outcome.
Okay. Other causes of acute severe MR listed include spontaneous chordal rupture, maybe in someone with underlying myxomatous mitral valve disease like MVP.
Yeah, one of the little heartstrings, the chordae tendineae, can suddenly snap. This causes a part of the mitral valve leaflet to become untethered, or flail, leading to abrupt, severe leakage.
Infective endocarditis is another cause mentioned.
Absolutely. An infection on the valve can rapidly destroy the valve tissue itself or the supporting chordae, causing acute severe MR.
And the source also mentions blunt chest wall trauma, even seemingly trivial trauma.
It's important to keep in mind, yeah. A sudden impact, like from a steering wheel in a car accident, even if it doesn't seem major externally, can cause contusion or rupture of a papillary muscle, or tear chordae, or even part of a leaflet, leading to acute dysfunction.
So TTE is indicated in all suspected cases of acute severe MIR to really define the mechanism, the severity, assess the left ventricle, and see if surgical repair is feasible.
It's the gold standard for that immediate assessment, no question.
Okay, so acute severe MR is one critical cause of early systolic murmurs. Another one listed is a small muscular ventricular septal defect, VSD.
Right. These are often congenital defects, holes present from birth, located in the muscular part of the wall between the two ventricles. The murmur is early systolic, specifically because that muscular part of the septum contracts during systole. And as it contracts, it progressively closes or narrows the defect, shutting off the flow relatively early in systole.
So the hole itself closes during systole. Interesting.
Exactly. These murmurs are typically localized, heard best along the left sternal border. Figure 42-2 shows this. And somewhat paradoxically, even though they are small defects, the murmur is usually very loud, often grade 4 or 5.
Why so loud if the hole is small?
It goes back to that pressure gradient and velocity idea. The pressure difference between the high-pressure left ventricle and the lower-pressure right ventricle is very large, especially in early systole. Driving blood through that small restrictive opening at very high velocity creates intense turbulence, hence the loud murmur and often a thrill.
And typically with these small muscular defects, you don't see signs of pulmonary hypertension or significant LV volume overload.
Correct. The amount of blood shunting across isn't large enough to cause those downstream hemodynamic consequences. However, the source makes an important distinction with large uncorrected VFDs, which are usually in the membranous part of the septum.
Okay, different location, larger hole.
Yes. These can lead to pulmonary hypertension over time. And when severe pulmonary hypertension develops, the murmur actually changes.
How does it change?
Well, it was likely holosystolic initially before the lung pressures went up, but as the right ventricular pressure rises significantly due to pulmonary hypertension, the pressure gradient across the septum, especially later in systole, decreases.
Okay.
So the shunt flow, and therefore the murmur, becomes limited mainly to early systole when the LV-RV pressure difference is still greatest.
So a large VSD with severe pulmonary hypertension could, in theory, mimic the timing of a small muscular VSD murmur.
The timing? Yes, potentially. But the clinical picture would be very different. You'd expect to find other signs of severe pulmonary hypertension like a palpable right ventricular lift, a loud pulmonic component of S2, maybe S2 is single or narrowly split, and the murmur itself might actually be softer overall than the booming murmur of a small restrictive VSD. TTE is necessary for any suspected VSD to sort this out.
Got it. Okay, the third cause of early systolic murmurs listed in the source is tricuspid regurgitation, TR, but specifically in the setting of normal pulmonary artery pressures.
Yes, this is a particular scenario. The source gives infective endocarditis affecting the tricuspid valve as an example. Because the pressures on the right side of the heart are normal and relatively low in this situation, the murmur of TR is usually soft, maybe grade 1 or 2.
And where is it heard?
Best heard at the lower left sternal border.
And the key distinguishing feature mentioned?
It typically increases in intensity with inspiration. This is known as Carvalho's sign.
Carvalho's sign. Why does inspiration make it louder?
Inspiration increases venous return to the right side of the heart. More blood coming back means more blood flowing across the tricuspid valve, both forward and, in this case, backward, due to the regurgitation. This augmented flow increases the turbulence and thus the murmur intensity.
Okay. Might you see other sign maybe in the neck veins?
Yes, you might see regurgitant CV waves in the jugular venous pulse. These large waves reflect the backflow into the right atrium and venous system during systole. But importantly, the source emphasizes that without pulmonary hypertension, this type of TR is not usually associated with signs of right heart failure like ascites, fluid in the belly, or peripheral edema, leg swelling. Those tend to occur with more severe TR, especially when right-sided pressures are elevated or there's chronic volume overload.
Okay, that clarifies the early systolic group. Now let's move on to mid-systolic murmurs. These start a short interval after S1 and before S2 and usually have that crescendo, decrescendo, diamond shape we talked about. Figure 42-1C.
Right. This is a large and very important category. Probably the most common cause in adults is aortic stenosis, or AS narrowing of the aortic valve.
And where is that typically loudest?
Usually loudest to the right of the sternum in the second intercostal space. It's often called the aortic area. Figure 42.2 shows this well, and it classically radiates upwards into the carotid arteries in the neck.
We mentioned the Gallivarden effect earlier, the AS murmur transmitting down to the apex and sounding higher pitched there, potentially mimicking Millar.
Exactly. It's a key thing to be aware of. And the source offers a really powerful maneuver to help differentiate that apical AS murmur from a true MR murmur. Listen to the intensity of the murmur in the beat after a premature ventricular contraction, a PVC.
The post-PVC beat. The source says the AS murmur gets louder after a PVC, while an MR murmur's intensity remains relatively unchanged. Why is that?
It's physiology. After a PVC, there's a longer pause, allowing for increased diastolic filling of the left ventricle. Plus, there's something called post-extrasystolic potentiation, where the contractility of the next beat is stronger.
Okay.
Both factors lead to a larger stroke volume being ejected and higher flow velocity across that stenotic aortic valve in the beat following the PVC. This increased flow velocity causes a bigger pressure gradient and makes the AS murmur louder. The pressure gradient driving MR, the LV to LA gradient, is less affected by these changes in loading and contractility.
That's a neat trick. The source also notes the AS murmur intensity varies directly with cardiac output.
Yes, it gets softer in states of low cardiac output, like severe heart failure, even if the stenosis itself is severe.
Yeah.
Because there's just less flow going across the valve.
What are some of the other auscultatory findings that suggest severe AS?
The source lists several key ones to listen for. A soft or even absent aortic component of S2 because a stiff calcified valve doesn't snap shut loudly. Paradoxical splitting of S2, where A2 is delayed so much it occurs after P2, and the split narrows or closes with inspiration, the opposite of normal.
Cool.
An apical S4 gallop sound due to the stiff, hypertrophied, left ventricle resisting filling during atrial contraction. And the murmur itself becomes later peaking. That crescendo-decrescendo shapeshifts, so the peak intensity occurs closer to S2 as the obstruction worsens.
In younger patients with congenital valvular AS, the source mentions an early ejection sound or click.
Yes, often heard at the left sternal border or the base. This click signifies that the valve leaflets, while stenotic, are still relatively mobile and not heavily calcified. It's often associated with a bicuspid aortic valve, and it helps localize the obstruction specifically to the valvular level, as opposed to above or below the valve.
What about associated findings outside of just listening? The carotid pulse.
Right. With severe AS, you might feel a carotid pulse that is small in volume and has a delayed upstroke. This is termed parvus atardus, though the source wisely notes this sign is less discriminatory in older patients who might have stiff arteries from other causes.
And the ECG?
The ECG often shows signs of left ventricular hypertrophy, LVH, as the severity of the AS increases. TDE, the echocardiogram, is really the go-to diagnostic tool for AS. It assesses the valve anatomy, quantifies the severity, checks LV size and function, and looks at the aortic root as well.
Okay, that's a deep dive into AS. What's another major cause of a mid-systolic murmur, according to the source?
Hypertrophic obstructive cardiomyopathy, or HOCM.
HOCM, where is that typically heard?
Usually loudest along the left sternal border or sometimes in the area between the lower left sternal border and the apex. Again, figure 42.2 gives a good indication. Now, the mechanism here is key. HOCM involves a thickened heart muscle, particularly the septum, that obstructs blood flow out of the left ventricle during systole. It's a dynamic obstruction, meaning it changes depending on conditions. And often there's associated mitral regurgitation because the anterior leaflet of the mitral valve can get pulled into the outflow tract during something called systolic anterior motion, or SAM.
Okay, dynamic obstruction and often MR2. And a defining feature, the source stresses, is how its intensity changes dramatically with provocative maneuvers.
This is absolutely crucial for bedside diagnosis. It's one of the most dynamic murmurs. Maneuvers that decrease the volume of the left ventricle or increase its contractility tend to worsen the outflow obstruction and make the HOCM murmur louder.
Like what maneuvers?
Think about the Valsalva maneuver, specifically the straining phase, or rapidly standing up from squatting. Both decrease venous return, making the LV cavity smaller. Vasodilator drugs, or things that increase heart muscle contractility and inotropes, can also worsen the obstruction and louden the murmur. The smaller cavity allows the thickened septum and the mitral leaflet to interact more forcefully.
Okay, so decreased LV volume makes HOCM louder. What about maneuvers that increase LV volume or increase the resistance the heart pumps against afterload?
These tend to reduce the obstruction and make the murmur softer. Examples include squatting from a standing position, passively raising the patient's legs, giving intravenous fluids, or using drugs that constrict blood vessels, vasopressors, or slow the heart rate and reduce contractility, beta blockers.
Why do those help?
Increasing preload makes the ventricle larger, which tends to widen the outflow tract. Increasing afterload means the ventricle has to push harder against systemic resistance, which can sometimes decrease that dynamic interaction between the septum and the mitral valve.
So the simple rule, Valsalva or standing makes HOCM louder. Squatting makes it softer. That's a really powerful diagnostic distinction.
It really is. Associated findings with HOCM can include a sustained, forceful apical impulse, often an S4 sound, maybe reversed S2 splitting, though rare, and sometimes a carotid pulse that feels brisk initially but might have a dip in the middle, Bispherians pulse, and of course LVH on the ECG. TTE confirms the diagnosis by showing the thickened muscle and outflow obstruction.
The source also notes that both HOCM and mitral valve prolapse, MVP, murmurs change intensity with these maneuvers, particularly Valsalva, standing, and squatting, as shown in figure 42-3. How do you tell them apart?
You differentiate them based on the other associated findings. HOCM typically has evidence of LVH and no ejection click, whereas MVP often has that characteristic mid-systolic click preceding the murmur, and usually no LVH unless the associated MR is severe and chronic.
Got it. Okay, another cause of a mid-systolic murmur listed is congenital pulmonic stenosis, PS, narrowing of the pulmonary valve.
Right. This is also typically a crescendo-decrescendo murmur, but it's best heard in the second and third left intercostal spaces, the pulmonic area. Figures 42-2 and 42-4 point this out.
And its duration and the sound of S2 relate to severity.
Yes, the source explains that as the pulmonic stenosis gets worse, the murmur duration lengthens, peaking later in systole, and the intensity of the pulmonic component of S2-P2 diminishes or becomes delayed. Figure 42-1D illustrates this. Severe PS delays P2 closure significantly, making it soft or even inaudible.
An early pulmonary ejection sound, or click, is common here too, especially in younger patients with a still mobile valve.
Yes, and unlike the aortic ejection sound in AS, the pulmonary ejection sound typically decreases in intensity with inspiration. That's a helpful distinguishing point.
And severe PS can lead to signs of right ventricular pressure overload.
Correct. You might feel a parasternal lift, the RV pushing against the chest wall, and see signs of right ventricular hypertrophy, RVH, on the ECG. A chest X-ray might show post-stenotic dilation of the main pulmonary artery. TTE is recommended for characterizing PS.
Okay. Left to right intracardiac shunting, like through an atrial septal defect, ASD, can also cause a mid-systolic murmur, but it's not the shunt itself making the noise.
That's a key point. The murmur associated with an ASD isn't usually the sound of blood flowing through the hole in the atria. That flow is typically low velocity. Instead, a significant left-to-right shunt causes increased blood volume flowing through the right side of the heart and out the pulmonary artery. So the mid-systolic murmur you hear, usually grade 2 or 3 at the middle to upper left sternal border, is actually due to this increased flow velocity across the normal pulmonic valve. It's a relative pulmonic stenosis murmur due to high flow.
And the absolute hallmark associated S2 finding with an ASD.
Fixed splitting of S2. The split between A2 and P2 is wide, and crucially, it doesn't change with respiration.
Why fixed?
Because the right ventricle is constantly dealing with that increased volume load from the shunt, regardless of breathing. This consistently delays P2 closure, keeping the split wide throughout the respiratory cycle. Ostium secundum type ASDs are the most common ones found in adults. TTE confirms the diagnosis and shows the shunt.
The source mentions a couple of other less common causes of mid-systolic murmurs, like idiopathic dilation of the pulmonary artery, but then it makes a really critical distinction about benign mid-systolic murmurs.
Yes, this is incredibly important clinical knowledge because these are very common and don't represent disease. These are typically soft, grade 1 or maybe 2. They occur in people who are asymptomatic and have absolutely no other signs or symptoms of heart disease.
And the source explicitly states, what about evaluation?
It says that for these truly benign-sounding murmurs in an otherwise healthy person, no further evaluation, including TTE, is usually necessary.
That's huge. It saves a lot of unnecessary worry and cost. What are some examples of these benign murmurs?
Well, a common one in older adults is due to aortic valve sclerosis. This is just some thickening or calcification of the aortic valve leaflets that doesn't actually obstruct flow. It can cause a soft crescendo-decrescendo murmur heard at the second right interspace, but the carotid pulses are normal and there's no LVH on the ECG. Then there are physiologic murmurs caused by accelerated blood flow in high-output states, fake pregnancy, severe anemia, or hyperthyroidism. These are usually soft, grade 1 or 2, often heard best along the left sternal border. And the classic Stills murmur in healthy children and adolescents, typically grade 2, often described as vibratory or musical, heard at the mid or lower left sternal border, usually loudest when lying down, figure 42-2.
So when does a soft grade 1 or 2 mid-systolic murmur warrant getting an echo, TTE?
The source clarifies this well. TTE is recommended for uncertain grade 2 or louder murmurs, or for any mid-systolic murmur, even soft ones, if the patient has any cardiovascular symptoms, like chest pain, shortness of breath, fainting, or other signs suggestive of heart disease, including an abnormal ECG or chest X-ray.
But if it's truly isolated soft, grade 1 or 2, in an asymptomatic person with a completely normal rest of the exam and normal ECG CXR if done,
then it's highly likely to be benign, and further investigation isn't usually needed.
Okay, that's a very practical approach. Let's move on to late systolic murmurs. The source says these are most often due to mitral valve prolapse, or MVP.
That's right. MVP occurs when one or both mitral valve leaflets billow back, or prolapse, into the left atrium during systole. The murmur is typically heard best at the left ventricular apex.
And it's often introduced by a sound.
Yes, very characteristically, it's often preceded by one or more mid-systolic non-ejection clicks. These clicks are thought to occur when the prolapsing leaflets suddenly tense up. Figure 42-3 shows this click murmur sequence. The murmur itself happens after the click, representing the mitral regurgitation that occurs due to the prolapse.
The radiation pattern of the murmur can actually give clues about which leaflet is primarily involved.
It can, yeah. If the posterior leaflet is prolapsing or flail, the regurgitant jet is directed anteriorly and medially towards the aorta, so the murmur might radiate toward the base of the heart and sometimes can even be mistaken for aortic stenosis if you're not careful.
Interesting. And if the anterior leaflet is the problem?
Then the jet is directed posteriorly. So the murmur tends to radiate towards the axilla or even the left infrascapular region around the shoulder blade.
What if a leaflet is actually flail, meaning a cord has broken?
Flail leaflet usually causes more severe MR, and the murmur is often louder, maybe grade 3 or 4, and can sometimes be heard quite widely over the precordium, especially in thin patients. The presence of an S3 sound or a short, rumbling mid-diastolic murmur, which we'll get to, would also suggest significant associated MR.
And AVP murmurs, like HOCM murmurs, respond very distinctively to dynamic maneuvers.
They absolutely do. They behave similarly to HOCM in response to changes in preload. Figure 42-3 illustrates this beautifully. Maneuvers that decrease venous return and LV volume, like standing up quickly or the Valsalva strain, cause the mitral valve to prolapse earlier in systole because the smaller ventricle offers less support. So the click and the onset of the murmur move closer to S1, and the murmur itself often becomes louder and longer.
Okay, earlier, louder, longer with decreased volume. What about increasing LV volume, like squatting?
Squatting abruptly increases both venous return, preload, and afterload. This increases LV volume, which tenses the mitral apparatus more, delaying the onset of prolapse. So the click and the murmur move later in systole, further away from S1, and the murmur typically becomes softer and shorter.
That dynamic response click murmur earlier with standing Valsalva, later with squatting, is highly characteristic of MVP, isn't it?
Extremely characteristic. It really helps nail the diagnosis at the bedside.
The source also briefly mentions that a transient late apical systolic murmur can sometimes occur with acute myocardial ischemia.
Yes. Temporary dysfunction of the papillary muscles or changes in LV geometry due to ischemia can cause the mitral leaflets to not close properly late in systole, leading to a murmur. Its intensity might vary with blood pressure, increasing if the afterload is high. TTE is generally recommended for evaluating any persistent late systolic murmur, primarily to assess for MVP and quantify any associated missed ART.
Okay, that covers late systolic. The final systolic category is holosystolic murmurs, sometimes called pansystolic. These start right with S1 and continue all the way through systole up to S2. Think figures 42-1b and 42-5.
That's the timing. They occupy the entire systolic period. These murmurs usually indicate either chronic mitral or tricuspid valve regurgitation or a ventricular septal defect, VSD, and they generally warrant a TTE for further characterization.
Let's start with chronic mitral regurgitation, MR. Where is it best heard? Radiation.
Best heard at the left ventricular apex and typically radiates towards the axilla. It's usually described as high-pitched and has that plateau configuration we discussed earlier.
Right, the plateau shape. Why again?
Because in chronic MR, the pressure difference between the high-pressure LV and the relatively low-pressure LA remains wide and fairly constant throughout systole. Unlike an acute MR, the left atrium has usually had time to dilate and become more compliant, so it can accept that regurgitant volume without its pressure shooting up rapidly. This maintains the gradient and the flow throughout systole.
What are common causes of chronic MCR?
The source lists several. Rheumatic heart disease causing scarring, calcification of the mitral annulus, common in older adults, structural changes to the LV after a heart attack, post-infarction remodeling, or severe enlargement of the LV cavity itself in conditions like dilated cardiomyopathy.
And the source mentions the concept of MNR begets NR. What does that mean?
It's a key insight into the progression of the disease. The chronic volume overload on the left atrium and left ventricle causes them to gradually enlarge. This enlargement stretches the mitral valve annulus, the ring the leaflet's attached to.
Okay.
Stretching the annulus makes it harder for the leaflets to meet and close properly, which increases the amount of Mr. More. MR leads to more volume overload, causing further enlargement, which worsens the MR. It becomes a vicious cycle.
A downward spiral. What are findings suggesting severe chronic MNR?
You look for signs of LV enlargement, like a displaced and enlarged apical impulse. You might hear an S3 gallop sound due to the rapid filling of the volume overloaded ventricle. And sometimes, as we hinted, a short mid-diastolic flow murmur across the mitral valve because of the increased volume coming from the LA.
Okay. Now, chronic tricuspid regurgitation, TR. How does that sound compared to MCR?
Generally softer than MISIP. It's loudest at the left lower sternal border. And the key dynamic feature is that it usually increases in intensity with inspiration Carvalho sign again.
And the most reliable sign might not even be the murmur.
Often, yes. The source emphasizes that prominent, large, regurgitant CV waves seen in the jugular venous pulse in the neck are frequently the most striking and reliable finding in severe TR, sometimes present even when the murmur itself is faint or inaudible.
You'd also look for other signs of right heart failure.
Absolutely. An enlarged and pulsatil liver, fluid in the abdomen, ascites, and peripheral edema, swelling in the legs and feet. Those abnormal jugular venous waveforms are really key, though.
What causes chronic TR primary versus secondary?
Primary TR, meaning the problems with the tricuspid valve itself, is less common. Causes include myxomatous degeneration like prolapse, endocarditis, rheumatic disease, radiation therapy damage, carcinoid syndrome, congenital issues like Epstein's anomaly, or trauma perhaps from pacemaker leads or biopsy.
But secondary TR is more common.
Much more common, accounting for over 80% of cases. Secondary or functional TR is usually a passive process resulting from enlargement of the tricuspid annulus due to dilation of the right ventricle. This RV dilation is typically caused by pressure or volume overload from other conditions, like pulmonary hypertension, left-sided heart failure, or adverse RV remodeling after an infarct.
Okay. Lastly, for holosystolic, ventricular septal defect, VSD. Loudest where?
Loudest at the mid to lower left sternal border, figure 42-2. It often radiates widely across the precordium.
And a thrill.
A palpable thrill is present at the site of maximal intensity in most patients with a significant VSD murmur.
Does it change with inspiration?
No. Unlike TR, the VSD murmur intensity typically does not change with inspiration.
The source, again, highlights the difference in intensity based on the size of the defect.
Yes, it's somewhat counterintuitive. Small, restrictive VSDs, sometimes called maladie de Roget, have very loud murmurs, often grade 4 or 5, with a thrill. This is because the large, sustained pressure gradient between the LV and RV drives blood across the small hole at extremely high velocity.
And large defects.
With large, non-restrictive defects, the pressures in the two ventricles tend to equalize. The shunt flow might be large in volume, but the velocity is lower because the pressure gradient is smaller. So the murmur may actually be softer, or in cases of severe pulmonary hypertension, Eisenmenger syndrome, the shunt might reverse and the murmur could disappear altogether.
And the presence of that thrill in most VSDs helps distinguish VSD rupture from acute MR post-MI, as we touched on earlier. TTE is obviously needed for VSD assessment. Okay, that was an incredibly thorough deep dive into all the systolic murmurs based on Chapter 42. Let's now shift gears and move into diastolic heart murmurs, those occurring during ventricular filling or diastole. These are often less common than systolic murmurs, but frequently indicate significant pathology, right?
That's generally true, yes. Diastolic murmurs almost always warrant investigation. We'll start with early diastolic murmurs. These begin right after the second heart sound, S2, specifically after A2 or P2, and they're typically decrescendo in shape, starting louder and fading out.
And the primary example given is chronic aortic regurgitation, AR, leaky aortic valve.
Correct. The characteristics are typically a high-pitched, blowing decrescendo murmur. Figure 42.1e shows this pattern.
Best heard where? And is there a maneuver?
Best heard at the second right intercostal space, the aortic area, and also often along the left sternal border. The maneuver to enhance it is classic. Have the patient lean forward, take a deep breath in, blow it all the way out, and hold their breath in expiration. This brings the aortic root closer to the chest wall. Using the diaphragm of the stethoscope is key for this high-pitched murmur.
The source mentions that where the murmur radiates can actually give a clue to the underlying cause of the AR.
Yes, this is an important point. If the cause is primary disease of the valve leaflets themselves, like a congenital bicuspid valve, prolapse, endocarditis damage, trauma, post-valvotomy changes, or rheumatic deformity, the murmur tends to radiate down along the left sternal border and may even be loudest there.
Okay. And if the cause is a disease of the aortic root?
If the problem is dilation or distortion of the aortic root and annulus, which prevents the leaflets from coapting properly, the murmur may radiate more down the right sternal border.
What kind of aortic root diseases cause this?
The source lists examples like Marfan syndrome causing an aneurysm, other causes of annular aortic ectasia, general dilation, complications of aortic dissection, medial degeneration of the aorta, severe long-standing hypertension, or even tertiary syphilis, which causes widening of the commissures.
Interesting distinction based on radiation. Now, the Austin Flint murmur, this is associated with chronic severe AR, right?
Yes. It's described as a lower-pitched, rumbling, mid to late diastolic murmur, usually soft, grade 1 or 2, heard at the apex. It's not a separate valve problem like mitral stenosis.
What causes it then?
The mechanism is thought to be turbulence created at the mitral valve inflow area. You have the normal forward flow coming from the left atrium into the LV, but at the same time you have that regurgitant jet of blood shooting back from the aorta. The collision or interaction of these two streams across the mitral valve leaflets is thought to cause the rumble.
How do you distinguish this Austin Flint rumble from true mitral stenosis, MS, which is also a diastolic rumble at the apex?
Couple of key insights from the source. First, the Austin Flint murmur has no opening snap. An opening snap is characteristic of pliable rheumatic MS. Second, their response to certain agents, like the vasodilator amyl nitrite, though rarely used now, the principle holds. Amyl nitrite decreases peripheral resistance, lowering diastolic blood pressure and thus reducing the aortic to LV pressure gradient that drives AR.
Okay.
So the AR murmur, and consequently the Austin Flint murmur, which depends on it, becomes shorter and softer. True MS, on the other hand, involves a fixed obstruction. Amyl nitrite might actually increase heart rate and cardiac output, leading to more flow across the stenotic mitral valve, potentially making the MS murmur remain constant or even increase in intensity.
That's a clever physiological distinction. The source also notes that a mid-systolic ejection murmur is actually quite frequent in patients with isolated severe AR.
Yes, this is due to the increased straight volume the LV has to pump out to compensate for the leak. More forward flow across the aortic valve, even if it's not stenotic, can create a grade 2 or 3 mid-systolic murmur. So you shouldn't automatically assume coexistent aortic stenosis just because you hear a systolic murmur in someone with severe AR. Accurate bedside identification of true concomitant AS usually requires other clues, like an abnormal carotid pulse or a systolic murmur that's grade 4 or louder.
And the peripheral signs of chronic severe AR are quite classic, resulting from that diastolic runoff of blood from the aorta.
They are. Things like a very wide pulse pressure, large difference between systolic and diastolic BP, a bounding and collapsing carotid pulse, Waterhammer or Corrigan's pulse, visible pulsations in the nail beds, Quincy's pulses, or a to and fro murmur heard over the femoral artery when compressed, Garosius' sign. These all indicate significant diastolic runoff and volume overload.
But the murmur of acute severe AR is different?
Markedly different, yes. It's notably shorter in duration, often lower pitched, and can be quite difficult to appreciate, especially with a rapid heart rate.
Why the difference?
Because in acute AR, the left ventricle is usually unprepared and non-compliant. The sudden large regurgitant volume causes the LV diastolic pressure to rise very abruptly. This rapidly eliminates the pressure gradient between the aorta and the LV during diastole.
The gradient disappears quickly.
Exactly. So the murmur is short. It might even cause premature closure of the mitral valve, leading to a soft first heart sound, S1. And importantly, those dramatic peripheral runoff signs we just discussed are generally absent in acute severe AR because the diastolic pressure doesn't have time to fall that low. TTE is essential for evaluating all forms of AR, both acute and chronic.
Okay. The other main cause of an early diastolic murmur listed is pulmonic regurgitation, PR, leaky pulmonic valve. This is known as the Graham-Steele murmur when it's associated with pulmonary hypertension, PHTM.
Correct. It's also a decrescendo murmur, occurring early to mid-diastole, but it begins after the pulmonic component of S2, P2, not A2.
Best heard where?
Usually best heard in the second left intercostal space, the pulmonic area. It tends to radiate down along the left sternal border. And like other right-sided murmurs, its intensity may increase with inspiration. Carvalho sign.
What's the most common cause of this Graham-Steele murmur?
By far the most common cause is dilation of the pulmonic valve annulus due to chronic severe elevation of pulmonary artery pressure, pulmonary hypertension from any cause.
How do you distinguish it from the similar-sounding AR murmur?
The key is the associated findings of pulmonary hypertension. You'd look for a palpable right ventricular lift, a loud P2 component of S2. Often S2 is loud and single, or very narrowly split because P2 is so loud and occurs close to A2. These signs point towards PHTN and therefore PR as the likely cause of the early diastolic murmur.
What about PR without pulmonary hypertension?
That can happen, though less commonly. Causes might include endocarditis on the pulmonic valve, a congenitally deformed valve, or sometimes after surgical repair of conditions like tetralogy of Fallot. In these cases without PHTN, the PR murmur is typically softer, lower pitched, and the severity can be harder to appreciate just by listening. TTE is indicated for all suspected early to mid-diastolic murmurs. The source also emphasizes the importance of longitudinal assessment with imaging for valvular disease to track severity and ventricular response, which guides timing for potential surgery. And if aortic root disease is suspected as the cause of AR, imaging the aorta itself with TTE, CT, or MR angiography is crucial.
Makes sense. Okay, moving on from early diastolic to mid-diastolic murmurs, what causes these?
These generally result from either obstruction to flow across the mitral or tricuspid valves during diastole, or sometimes from significantly augmented flow across normal valves.
The most common cause of obstruction mentioned is mitral stenosis, MS, usually from rheumatic fever, right?
Yes. Historically, rheumatic fever has been the most common cause worldwide, leading to scarring and fusion of the mitral valve leaflets.
What are the classic auscultatory findings, especially in younger patients whose valves might still be somewhat pliable?
You often hear a loud first heart sound, S1, because the stiff leaflets snap shut forcefully. And shortly after S2, you hear the opening snap, OS.
Tell me more about the opening snap.
The OS is a high-pitched sound, like a snap, that occurs when the stenotic but still somewhat mobile mitral valve abruptly halts its opening excursion in early diastole. Here's a critical insight from the source. The timing of the OS relative to S2 is inversely related to the severity of the MS.
Inversely related, so a shorter interval means?
A shorter interval between S2, specifically A2, and the OS means more severe stenosis. This is because a higher left atrial pressure is needed to force the stiff valve open, and that higher pressure achieves the necessary opening pressure earlier in diastole. So A2-OS interval shortens as LE pressure rises and stenosis worsens.
That's a very useful clinical sign. What about the murmur itself?
The murmur of MS is characteristically low-pitched and rumbling. It's best heard with the bell of the stethoscope lightly applied to the skin.
Location.
Maneuver. Loudest, right at the left ventricular apex. And crucially, it's often faint or even inaudible unless the patient is turned into the left lateral decubitus position, lying on their left side. This brings the LV apex closer to the chest wall.
The duration of the murmur relates to the obstruction.
Yes, generally, a longer murmur duration implies more significant obstruction, as the pressure gradient between the LA and LV persists for longer during diastole.
And intensity changes.
The intensity tends to increase during maneuvers that increase cardiac output and flow across the mitral valve, like exercise or sometimes just after a few sit-ups. The duration reflects how long the LA pressure remains higher than the LV diastolic pressure.
The source also mentions presystolic accentuation. What's that? Reference figs 42.1a and 42.6.
This is an increase in the intensity of the rumble just before S1. It occurs only in patients who are in normal sinus rhythm. It's caused by the late diastolic boost in transmitral flow generated by atrial contraction, atrial kick. This extra flow across the stenotic valve just before systole makes the murmur louder.
And crucially, this presystolic accentuation disappears if the patient develops atrial fibrillation.
Exactly, because you lose that organized atrial contraction.
What about tricuspid stenosis? Much less common.
Much less common, yeah. Also, usually rheumatic in origin. The mid-diastolic rumble is heard best at the lower left sternal border. Like other right-sided sounds, it typically increases in intensity with inspiration, valves. You might also see a prolonged descent in the jugular venous waveform, reflecting slow emptying of the right atrium. But honestly, the murmur itself is often very difficult to hear, frequently obscured by louder left-sided sounds like coexisting MS.
Okay. Are there other causes of mid-diastolic murmurs besides MS and TS?
Yes, the source lists a few. Large left atrial myxomas, these are tumors in the left atrium, can sometimes prolapse across the mitral valve during diastole, causing variable obstruction. The murmur might change duration or intensity depending on the patient's body position. Unlike MS, there's no opening snap or true presystolic accentuation.
What about murmurs from increased flow, not obstruction?
Right. Significantly augmented diastolic flow across a normal mitral valve can produce a mid-diastolic rumble. This happens in conditions with severe isolated MR, lots of blood returning from the LA, large left-to-right shunts like VSD or PDA jumping extra volume into the LV, certain high-output states, or even complete heart block where diastolic filling periods are prolonged.
How does that sound?
It often sounds like a soft, rapid filling sound in S3, followed by a short, low-pitched mid-diastolic apical murmur. Figure 42-1G shows this. It's a flow rumble, not stenosis.
The Austin-Flint murmur of severe chronic AR also falls in this timing category, as we discussed.
Yes, mid to late diastolic rumble at the apex.
Then the Carey-Coombs murmur.
This is a rarely heard murmur associated with acute rheumatic fever. It's described as a short, mid-diastolic apical murmur, thought to be due to flow across an inflamed edematous mitral valve, valvulitis. It's transient and resolves as the rheumatic attack subsides. Importantly, there's no opening snap in the acute phase.
Complete heart block can cause intermittent diastolic murmurs.
Yes, if atrial contraction happens when the mitral valve is partially closed due to the AV dissociation, you can get intermittent mid to late diastolic murmurs.
And increased flow across the tricuspid valve can cause a rumble, too.
Yes, analogous to the mitral side. This can occur with severe isolated TR or large ASDs with significant left-to-right shunting, leading to high flow across the tricuspid valve. If it's due to an ASD, you'd expect to find the other signs like fixed S2 splitting and the pulmonic mid-systolic flow murmur.
TTE is indicated for evaluation of all these mid-diastolic murmurs.
Absolutely. Echo helps determine the cause, obstruction versus flow, quantify severity, assess chamber sizes, and guide management decisions.
Okay, that covers diastolic murmurs. The final major category is continuous murmurs. These are heard throughout the cardiac cycle.
Yes, they begin in systole, typically peak near S2, and then continue without interruption through S2 into all or at least part of diastole. Figure 42-1H shows this continuous pattern.
What does a continuous murmur signify physiologically?
It implies that a pressure gradient exists between two connected structures throughout the cardiac cycle, both systole and diastole, causing continuous turbulent flow between them. This usually involves a communication between a high-pressure system, like the systemic arterial circulation, and a low-pressure system, like the pulmonary arterial or venous circulation.
The source makes a point to distinguish this from tufro murmurs.
Right. A tofro murmur is a combination of two separate murmurs, like a systolic ejection murmur, example AS, followed by an early diastolic decrescendo murmur, by a G, for example. There's usually a silent interval between them, however brief. They represent flow in opposite directions during different phases. A continuous murmur is one single sound spanning systole and diastole, usually from flow in one direction due to a persisting gradient. Figure 42-7 contrasts these.
What's a classic example of a pathologic continuous murmur?
Patent ductus arteriosus, or PDA. This is the persistent connection after birth between the high-pressure aorta and the lower-pressure pulmonary artery.
Where is it heard?
Classically best heard just lateral to the upper left sternal border, sometimes described as being machinery-like in quality.
What happens if a large PDA shunt isn't corrected and leads to pulmonary hypertension?
As pulmonary artery pressure rises towards systemic levels, the diastolic pressure gradient between the aorta and PA diminishes. This causes attenuation or even complete obliteration of the diastolic component of the continuous murmur. Eventually, if PHTN becomes severe enough, Eisenmenger syndrome, the shunt flow can reverse right to left.
And that reversal can cause a specific sign.
Yes, differential cyanosis, where the lower extremities appear blue, cyanotic, because they receive desaturated blood from the pulmonary artery via the PDA, while the upper extremities remain pink as they get blood from the aorta before the ductus.
Are there other pathologic causes of continuous murmurs?
Yes, several are mentioned. A ruptured sinus of Valsalva aneurysm, this is often an abrupt onset, a bulge in the aorta near the valve ruptures, typically into a right heart chamber, RA or RV. Since aortic pressure is always higher than RA-RV pressure, you get continuous flow and murmur, often heard best at the upper right sternal border. Coronary arteriovenous fistulas, abnormal connections between coronary arteries and veins or chambers, can cause a continuous murmur, often along the left sternal border. An arteriovenous fistula, created surgically for hemodialysis access, will have a continuous murmur and thrill over the site.
Coarctation of the aorta?
In severe coarctation, the enhanced blood flow through enlarged intercostal collateral arteries bypassing the blockage can sometimes produce continuous murmurs heard along the ribs or back. And while not truly continuous, the source notes that high-grade carotid artery stenosis can cause a cervical brood that has both systolic and diastolic components, sometimes described as to-fro, distinct from a true continuous murmur originating in the chest.
Importantly, there are also benign continuous murmurs.
Yeah.
We need to be careful not to overinterpret these.
Absolutely crucial distinction. The most common is the venous hum.
Venous hum.
Yes, very common in healthy children and young adults, especially during pregnancy. It's caused by turbulent flow in the internal jugular veins. It's typically loudest in the right supraclavicular fossa above the collarbone.
And there are maneuvers to make it disappear.
Yes, that's key. Light pressure over the right internal jugular vein, or having the patient turn their head towards the examiner, usually obliterates the hum. That confirms its benign venous origin.
Another benign one mentioned is the mammary souffle of pregnancy.
Right. This is due to increased arterial blood flow in the engorged breasts, typically heard in late pregnancy, third trimester, or early postpartum. It's usually louder in systole, but can extend into diastole. Firm pressure with a stethoscope diaphragm can often eliminate the diastolic portion, helping identify it.
So knowing those obliteration maneuvers is key for the benign ones.
Definitely helps avoid unnecessary workup.
Okay, we've covered the characteristics and types of murmurs in incredible detail. Now, the source highlights dynamic auscultation as a crucial element, using these simple bedside maneuvers to actively change cardiac hemodynamics and observe how the murmurs respond. This really helps differentiate them, right? Table 42-2 in the source covers this conceptually.
It's incredibly powerful. These maneuvers provide vital diagnostic clues by altering preload, afterload, or contractility, and seeing the effect on the murmur's intensity, timing, or duration.
Let's start with respiration. How does breathing affect murmurs?
The general rule is to listen during quiet respiration, or maybe modest inspiration. Forceful breathing can create too much noise and obscure the sounds. Generally, left-sided heart murmurs are best heard at end expiration, when the reduced lung volume brings the heart closer to the chest wall. The murmur of AR is a classic example.
And right-sided murmurs.
Right-sided murmurs, like TR, TS, and PR, typically increase in intensity during inspiration. That's Carvalho's sign again, due to increased venous return to the right heart. Left-sided murmurs, in contrast, usually remain constant or decrease slightly with inspiration.
Respiration also famously affects the splitting of the second heart sound, S2. Figure 42-8 illustrates this.
Yes, assessing S2 splitting is fundamental. Normally, S2 splits into its A2 and P2 components only during inspiration, as increased venous return delays P2 closure.
What are abnormal splitting patterns?
Wide physiologic splitting means P2 is delayed more than usual, e.g. due to RBBB or pulmonic stenosis, or A2 closes early, for example, severe MR, but the split still widens normally with inspiration. Fixed splitting, as we mentioned with ASD, means the split is wide and doesn't change at all with respiration.
And reversed splitting.
Reversed or paradoxical splitting means A2 is abnormally delayed due to things like severe AS, HOCM, LBBB, or RV pacing, so it occurs after P2 during expiration. During inspiration, the normal delay of P2 brings it closer to the already delayed A2, so the split actually narrows or closes with inspiration the opposite of normal. Recognizing these S2 patterns is very helpful.
Okay, moving on to maneuvers that alter systemic vascular resistance, or afterload. What happens when you increase afterload, like with sustained hand grip exercise, or inflating blood pressure cuffs on both arms, or using vasopressor drugs?
Increasing afterload makes it harder for the left ventricle to eject blood forward. This tends to increase backward flow in regurgitant lesions. So the systolic murmurs of MR and VSD typically become louder.
What about outflow obstruction murmurs?
Murmurs of AS or HOCM usually become softer or remain unchanged because the increased resistance might actually decrease the flow velocity or gradient across the obstruction. And the diastolic murmur of AR becomes louder because the higher systemic diastolic pressure increases the backflow gradient into the LV.
Now, what about maneuvers that decrease afterload, like using inhaled amyl nitrate? Understanding it's rarely used, but the principle is key.
Decreasing afterload makes it easier to eject blood forward and harder to flow backward. So, murmurs related to forward flow obstruction, like AS or HOCM, tend to increase in intensity because more blood is ejected forward rapidly.
And regurgitant murmurs.
Murmurs of MR or VSD become softer because the lower systolic resistance favors forward flow out the aorta rather than backward leak. The Austin-Flint murmur, dependent on AR, also becomes softer. Interestingly, the mid-diastolic rumble of MS might become louder with amyl nitrate due to reflex tachycardia increasing flow across the valve.
Okay, that covers afterload changes. What about maneuvers that primarily change venous return or preload? The Valsalva maneuver is a classic.
Right. During the straining phase of Valsalva, bearing down, intrathoracic pressure increases sharply, which decreases venous return to the heart. Less blood filling the heart means lower ventricular volumes and reduced cardiac output.
How does this affect most murmurs?
Most murmurs decrease in intensity during the Valsalva strain because there's simply less blood flowing.
But there are two notable exceptions.
Exactly. The murmurs of MVP and HOCM typically become louder during the Valsalva strain. For MVP, the murmur may also become longer because the prolapse happens earlier in the smaller ventricle. This differential response is very diagnostically useful.
What about rapidly standing up versus squatting? These also primarily affect preload.
Yes. Standing up quickly from a squat or lying position causes blood to pool in the legs, decreasing venous return and LV volume directionally similar to the Valsalva strain. So again, the murmurs of MVP and HOCM usually get louder with standing. For MVP, the click and murmur also move earlier, closer to S1, figure 42-3.
And squatting.
Squatting does the opposite. It abruptly increases venous return, preload, by squeezing blood out of the legs. A&D, it also increases afterload by compressing femoral arteries. Both effects increase LV volume.
So how do MVP and HOCM respond to squatting?
They become softer and shorter in duration. The increased LV volume reduces the outflow obstruction in HOCM and delays the onset of prolapse in MVP, moving the click and murmur later, away from S1. Again, figure 42-3 is key here.
Passive leg raising is another way to increase venous return.
Yes, simply lifting the patient's legs increases preload. This typically decreases the intensity of the HOCM murmur. It might have less effect on the MVP murmur compared to squatting, which also adds the afterload component.
One last dynamic auscultation technique. Listening to the beat after a premature ventricular contraction, PVC.
We touched on this regarding AS versus MR. It's about assessing murmur intensity in the cardiac cycle, immediately following a PVC, or similarly after a long RR interval during atrial fibrillation.
So to recap, murmurs due to AS or other LV outflow obstruction.
They increase in intensity in the post-PVC beat. This is due to the combination of enhanced ventricular filling during the preceding pause and the increased contractility, post-extrasystolic potentiation, leading to accelerated forward flow and an increased pressure gradient across the obstruction.
And MR murmurs.
The intensity of the MR murmur typically does not change significantly in the post-PVC beat. The LV to LA pressure gradient driving the regurgitation is relatively less affected by the changes in loading and contractility compared to the outflow gradient.
These dynamic maneuvers really seem like powerful bedside tools to help sort out different murmurs.
They absolutely are. When used correctly and interpreted in context, they can significantly narrow down the diagnostic possibilities before any imaging is even done.
Which brings us to the next point. All this detailed auscultation and dynamic assessment doesn't happen in a vacuum. It has to be integrated into the full clinical picture.
Precisely. Understanding the murmur is just one piece, although a crucial one. You have to combine it with the patient's history, their symptoms, other physical exam findings like the character of the jugular venous pulse, the arterial pulses, other heart sounds, listening to the lungs, examining the abdomen, skin, extremities, and the overall clinical context. Table 42-1 provides a conceptual framework for this integrated differential diagnosis.
Existing lab studies, an ECG, or a chest X-ray can also provide valuable supporting information.
Definitely. The source gives some good examples. If you hear a new murmur in a patient with fever, chills, fatigue, shortness of breath, maybe an enlarged spleen or petechiae, and positive blood cultures, you're highly suspicious of infective endocarditis causing valve damage.
Or a new systolic murmur appearing suddenly after a heart attack in a patient whose blood pressure plummets.
That strongly suggests a mechanical rupture, like a VSD or papillary muscle rupture. Conversely, finding an isolated, soft grade 1 or 2 mid-systolic murmur in an otherwise completely healthy, asymptomatic young adult most likely benign, as we discussed. The context really dictates the urgency and necessity of further testing.
And the primary tool for further testing when indicated is echocardiography, TTE.
Yes, TTE is described as a valuable tool, and Figure 42-9 provides a conceptual strategy diagram. It gives a wealth of information non-invasively. Detailed valve structure and function, chamber sizes, wall thickness, overall heart function, estimated pulmonary artery pressures, detection and quantification of intracardiac shunt flow, and assessment of venous and aortic flow patterns.
The source adds a small caution about Doppler echo.
Yes, it notes that Doppler is very sensitive and can often detect trivial or mild degrees of valve regurgitation, even across anatomically normal valves. These trace leaks are often hemodynamically insignificant and not likely to be the source of an audible murmur. So you have to correlate the echo finding with the auscultation.
So when is TTE generally recommended based on the murmur findings?
The source provides clear indications. Any early, late, or holosystolic murmurs. Mid-systolic murmurs that are grade 3 or louder. Mid-systolic murmurs that are softer, grade 1 or 2, but occur in a patient with cardiovascular symptoms or other signs of heart disease, including an abnormal ECG or chest X-ray. Any diastolic murmur. And continuous murmurs that are not clearly identifiable as a benign venous hum or mammary souffle.
Also for ruling out structural disease.
Yes, sometimes TTE is used when there's a clinical need to verify normal heart structure and function in patients who have symptoms that are likely non-cardiac, just to be certain. And importantly, serial TTEs play a crucial role in monitoring patients with known asymptomatic valvular disease over time to guide the optimal timing for surgical intervention before irreversible damage occurs.
And when is routine TTE not recommended?
Specifically for asymptomatic patients who have only an isolated grade 1 or 2 mid-systolic murmur with no other concerning signs or symptoms. If there's any residual doubt, referral to a specialist for evaluation might be considered, but routine echo isn't indicated based on the source.
The source also touches on newer technologies.
Yes, things like handheld or miniaturized ultrasound devices, which might improve detection sensitivity in some settings, though accuracy can be operator-dependent and cost-effectiveness less clear. Also, electronic or digital stethoscopes, which offer potential for amplification, recording, and perhaps better characterization or teaching. The source suggests these technologies should be seen as tools to augment, not wholesale replace, traditional skilled auscultation.
Okay. What if TTE and the clinical assessment are still insufficient to answer the clinical question? Are there other cardiac tests? Referencing Figure 42-9 again.
Yes, though this applies to relatively fewer patients now. Transesophageal echocardiography, TEE, where the ultrasound probe is passed down. The esophagus provides much clearer images, especially of posterior structures, when TTE windows are limited by body size, chest shape, or lung disease. TE has enhanced sensitivity for detecting certain structural disorders, like endocarditis vegetations or small shunts.
What about MRI or CT?
ECG-gated cardiac magnetic resonance, CMR, provides excellent quantitative information on valve function, like regurgitant fraction volume, shunt flow, chamber volumes, vessel sizes, ventricular function, and even myocardial perfusion or scarring. The source notes CMR has largely replaced invasive cardiac catheterization for quantifying regurgitant valve disease when TTE and clinical findings are discrepant.
And both CMR and cardiac CT.
They're very good for assessing aortic valve leaflet number. Is it bicuspid or tricuspid? When TTE is uncertain, and for detailed anatomy of the aortic root and ascending aorta. Coronary CT angiography might be used to exclude significant coronary artery disease in selected patients before valve surgery.
So cardiac catheterization and invasive hemodynamics are needed less often now.
Needed in fewer patients for primary diagnosis, yes, thanks to the advances in non-invasive imaging. However, cath is still used for complex valve disease when non-invasive findings are contradictory or to answer specific hemodynamic questions, sometimes involving dynamic measurements during exercise or drug infusion, especially preoperatively.
It really underscores the integrated approach.
Absolutely. The source summarizes it as a systematic process. Start with detailed auscultation, timing, attributes, maneuvers. Formulate a preliminary differential diagnosis. Refine that differential using the patient's history, the rest of the physical exam, and the overall clinical context. Determine the need for and urgency of further testing based on that refined picture. And finally, correlate all the findings. It also emphasizes considering costs and justifying imaging, while reiterating the time-honored tradition and enduring value of the stethoscope beyond just diagnosis. It's part of the physical connection and assessment.
Wow. We have truly gone deep into Chapter 42 today. From those first audible vibrations all the way through intricate pressure gradients, timing, shapes, intensity scales, locations, radiation patterns, dynamic maneuvers, and finally integrating it all with the full clinical picture and the sophisticated testing available.
It's a lot, but understanding the why behind the sounds, the physiology driving the turbulence, is what allows for true mastery, moving beyond just memorization to real clinical reasoning. It really is a systematic process of careful observation, analysis, and correlation.
And while our primary focus was Chapter 42 on murmurs, we did briefly acknowledge that other source on edema. It serves as a good reminder, doesn't it? Edema, or swelling, can certainly be a downstream consequence of severe cardiac issues causing fluid backup, like heart failure resulting from significant valve disease. But of course, edema has many other potential causes too: kidney problems, liver issues, venous insufficiency, medications.
Exactly. And the distribution of the edema, along with other signs and symptoms, helps point towards the likely cause. It reinforces that cardiac assessment, including listening for murmurs, is always part of evaluating the whole patient. You're constantly linking signs like murmurs to potential systemic manifestations like edema and vice versa, using those other signs to help interpret the significance of what you hear over the heart.
So, to truly master this information like the elite professionals, as we aimed for, it seems it's about combining that incredibly deep understanding of the murmur itself, derived from sources like Chapter 42, with the ability to see it clearly within the full context of the individual patient.
That's the art and science of it, isn't it?
Yeah.
A blend of focused, detailed listening and broad, holistic assessment.
Well, here's a final thought to leave you with. Building on the source's mention of technology and the enduring value of the stethoscope, we've spent this entire deep dive focused on the power of the trained human ear and careful auscultation. In this current era of truly incredible high-resolution cardiac imaging echo, MRI, CT, what enduring, unique value does the skill of expert auscultation still provide right there at the bedside? What is it about listening, about that interpretation by a skilled clinician, that current technology perhaps can't fully replicate?
That's a great question to ponder. There's something about that direct connection, the synthesis of information in real time.
Something to definitely mull over. Thanks for joining us for this incredibly detailed deep dive. We sincerely hope you feel significantly more informed and perhaps even a bit closer to mastering the complex and fascinating language of heart murmurs.